Good afternoon, folks. This afternoon's topic B is home, not alone, helping aging seniors in rural America. Home, not alone, helping aging seniors in rural America. On the back roads of rural America, aging has a particular quiet. It is the hum of a refrigerator in a kitchen where no one has visited in days. It's the long stretch of hours between sunrise and the moment someone finally calls to check in. It's independence, yes, but it's also vulnerability, the kind that hides behind pride and the familiar refrain, I'm managing. Okay, guys, I'm going to go through my presentation for y'all. So please join me. Please enjoy. But managing in rural communities often means managing alone. The nearest grocery store may be 20 miles away. The nearest mental health clinician, 40 broadband cuts out when the wind shifts. Adult children live states away, and the scaffolding that should support older adults, home care, transportation, care coordination, respite is thin or non-existent. This is not a failure of rural elders. It's a failure of the system around them. The geography of aging. Aging at home is the overwhelming preference of older adults. They want to remain in the houses they built, the farms they tended, and the towns where they raised their children. But in rural America, aging in place often means aging in isolation. The consequences are predictable, preventable falls, worsening chronic conditions or illnesses, deepening loneliness, and avoidable nursing home placement, not because elders are fragile, but because the infrastructure around them has eroded. Guys, this subject is right up my alley. Because for years in elder care, I saw this happen for years with folks that I have taken care of in the past. So, my story that I'm doing today is right up my alley. The consequences are predictable, preventable falls, worsening chronic illnesses, deepening loneliness, and avoidable nursing home placement. Not because elders are fragile, but because the infrastructure around them has eroded. Rural America is older than urban America. It has higher rates of disability, chronic disease, and poverty. Yet it has fewer clinicians, fewer home care workers, fewer transportation options, and fewer community based programs. The math is simple: more need, fewer supports, and the gaps compound. A missed appointment becomes a missed diagnosis. A misdiagnosis becomes a hospitalization. A hospitalization becomes a long-term placement that could have been avoided with a few hours of weekly help. The strengths we ignore, and yet rural communities hold extraordinary strengths. Strengths policymakers routinely overlook. Neighbors know one another's histories. They notice when the mail piles up. They remember who lost a spouse last winter. And who hasn't been seen at the diner in a week. Churches anchor social life. Paramedics know their customers by name. EMS volunteers show up at all hours. These are not just cultural assets, they are structured assets. The foundation for a rural aging strategy built on trusted local anchors like pastors, librarians, pharmacists, and volunteer fire departments. These are people who can spot trouble early and connect seniors to help. Rural, 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 a rural aging strategy should start with what rural communities already do well: relationship density. The policy question is how to support and strengthen those relationships, not replace them. What rural seniors actually need. What rural seniors need most isn't complicated. It's not high tech. It's not a new app or new platform. It's a it's it's consistent human help. Someone to check in, someone to drive them to the doctor, someone to make sure the stove is off, someone who notices when they stop coming to church. They need daily living support, meals, bathing, medication reminders. Transportation, not just to medical appointments, but to groceries, social events, and community life, social connection, structured opportunities to reduce isolation, care coordination, someone who can navigate Medicare, specialists, and community programs, respite for family caregivers who are stretched thin. These are not luxuries, folks. They are the basic conditions that allow older adults to remain safely at home. The policy failure we can fix. The biggest barrier is what Medicare is that Medicare is the primary insurer for older adults. Does not pay for most of what rural seniors need. It pays for medical care, not the daily supports that prevent medical crises. We need policy that reflects the reality of rural life. Expand Medicare reimbursement for home-based supportive care, not just skilled medical care. Fund mobile interdisciplinary teams that can reach remote seniors. Strengthen the caregiving workforce through training incentives and rural pipelines. Invest in broadband that actually works so telehealth isn't a luxury. Support community-based programs that leverage trusted local figures. Modernize transportation funding to include volunteer driver programs and micro transits. These are not radical ideas. They are practical, cost effective, and aligned with what rural communities already do well. Aging at home should not mean aging alone. We often talk about rural America as if it is defined by scarcity, but rural communities are defined by connection, the kind that is deep, durable, and woven through generations. Policy should honor that. Aging at home should not mean aging alone. Rural seniors deserve a care system that reflects their geography, their culture, and their humanity, one that meets them where they are, supports the independence they value, and keeps them connected to the communities they've spent a lifetime building. The question is not whether rural America can support its elders, it's whether we will choose to build the infrastructure that allows them to remain home, not alone. Okay, guys, here's the second half of the show for A. Home, not alone, helping aging seniors in rural America. Here's the storytelling half of my program today. Okay, Ruth, an 84-year-old widow in rural Pennsylvania, stood at her kitchen sink on a cold March morning. Starting a pill, uh, starting a pill bottle she couldn't open. Her arthritis had worsened, but she hadn't told anyone. Her daughter lived 3 states away. Her closest closest neighbor was a quarter mile down the road. The home health care aide, who used to visit once a week, had left the agency and there was no replacement. By evening, Ruth had missed 2 doses of her heart medication, not because she lacked medical care, but because she lacked the basic daily support that keeps older adults safe at home. This is not this is not an anecdote. It is a policy failure. The rural aging gap is a policy choice. Rural America is older than urban America, with higher rates of disability, chronic illness, and poverty. Yet the infrastructure that supports aging at home, home health care, transportation, care coordination, broadband, behavioral health is thinner in rural counties than anywhere else in the country. These gaps are not accidental. They are the predictable result of federal and state policies that fund medical care but not the daily supports that prevent medical crises. Medicare will pay for a skilled nurse to visit Ruth after she's hospitalized. It will not pay for the help that would have prevented the hospitalization in the first place. That misalignment drives cost up and drives older adults out of their homes. The core problem: Medicare's narrow definition of care. Medicare benefit structure was designed in 1965, an era where an era when aging meant acute illness, short hospital stays, and family caregivers lived nearby. Today, aging is defined by chronic disease, functional decline, and dispersed families, especially in rural communities. Yet Medicare still refuses to cover daily living supports like bathing, meals, and medication assistance, home based monitoring for frailty, cognitive decline, and social isolation. Transportation to medical appointments, groceries, and community life, respite for family caregivers, care coordination across fragmented systems. These are not the services that keep older adults safe at home. They are also the services rural communities lack most. The result is predictable, preventable hospitalizations, premature nursing home placement, and escalating Medicare spending, all because the program refuses to pay for low cost supports that would keep people stable. The rural workforce crisis is a policy crisis. Rural home rural home care agencies cannot hire enough workers because reimbursement rates are too low to offer competitive wages. Rural clinicians cannot provide home based care because Medicare's payment structure penalizes travel time. Rural EMS volunteers shoulder responsibilities that should belong to a funded care system. We need policy that acknowledges rural geography, increases in reimbursement for home care services in rural counties. Fund rural training pipelines for home healthcare workers, aides, and geriatric specialists. Create create rural travel time adjustments for home-based clinicians. Support volunteer driver programs with federal transportation dollars. These are not new ideas, folks. They are long delayed corrections. Leverage rural strengths instead of ignoring them. Rural communities have something urban areas struggle to replicate relationship dense relationship density. People know one another's histories. They notice when the mail piles up. They knew who lost a spouse last winter and who hasn't been seen at the dinner diner in a week. Policy should build on these strengths by investing in trusted local anchors, pastors, librarians, pharmacists, senior center staff, EMS volunteers who already serve as informational safety nets. Congress and state legislators should fund community health connectors who link isolated seniors to services, support micro transit and volunteer driver programs. Expand mobile interdisciplinary teams that bring care directly to remote homes. Invest in broadband that actually works so telehealth is reliable, not inspirational. These investments cost far less than the hospitalizations and nursing home stays they prevent. Aging at home should not mean aging alone. Ruth eventually got her pill bottle open. A neighbor stopped by the next day, but to she shouldn't have had to rely on chance. She shouldn't have to choose between independence and safety. And she shouldn't have to navigate aging alone. The policy path is clear. Modernize Medicare, strengthen the rural workforce, fund home-based care. Invest in rural infrastructure, support community anchors. Rural America does not need charity. It needs policy that recognizes its geography, its culture, and its people. Aging at home should not mean aging alone. Congress, CMS, and state legislators have the tools to fix this if they choose to use them. Okay, guys, that's your B for today. I will be back on with C and D in a bit after a short break. So we'll see everybody in a bit for shows after a break. For now, Gator Wellness, take care, folks.